Hello friends, today we're going to discuss about acute and transient psychotic disorder. I am Dr. Suresh Bhadat, Professor of Psychiatry, working at National Institute of Mental Health and Neurosciences, Bangalore. In this video, I'll be discussing about acute psychosis, how this acute psychosis has been evolved over a period of time in the academic literature, how to diagnose acute psychosis, management, and course and outcome of acute psychosis will be discussed in this video. Let's understand about acute psychosis. Acute psychosis refers to a sudden onset of psychotic symptoms that develop over a period of maybe 1 to 2 weeks. And the core disturbance is loss of contact with reality. The person may experience hallucinations, delusions, disorganized thinking, and marked changes in the behavior or mood. It may follow a stressful event. There will be sleep disturbance, substance abuse, possibility, or any underlying medical or psychiatric condition may be there. But we need to understand that acute psychosis need to be acute in onset. What do you mean by acute in onset? Less than 2 weeks. That is acute onset. So let's understand this concept of onset. If you take the duration in weeks, and if the psychotic symptom starts slowly over a period of time, and the time taken from change in behavior to the development of a diagnosable condition that is floridly symptomatic, the time taken is considered as onset. From change of behavior to the diagnosable condition. For example, if a patient develops insomnia 5 days back, 4 days back, he became restless, 3 days back, he became hostile, started abusing family members, 2 days back, he started telling people are trying to do something against him, and yesterday, he started talking to self, smiling to self, assaulting public at large, throwing stones at vehicles. So that's a floridly symptomatic. So this 5 days from the change of behavior to diagnosable condition is called as onset. And in acute psychosis, it should be within 2 weeks. So that's the classical presentation of acute psychosis. Not only that, the total duration of illness should not be more than 3 months. So the duration of total episode with or without treatment, the onset to the remission should be less than 3 months, and there should be a complete recovery. Then only we call it as an acute psychosis, my dear friends. So how to ask this onset? The acute onset, you need to be trained to assess this onset period. So there are some questions I would like to propose here so that you can use when you want to assess onset. You need to ask any recent changes in the behavior. When did you notice the first behavior? What was the first change you noticed in him? Did these symptoms start suddenly or gradually? What do you think? And when do you think he was completely all right? How long it has been since the behavior started to interfere in daily functioning? Was there any stressful event which led to these symptoms? When did family members believe that he requires psychiatric consultation? When was this hallucination and unusual belief started? So these questions need to be asked. That is, change from premorbid level of functioning to a diagnosable condition. The time taken for that is considered as onset, my dear friends. Now let's look into what is the importance of this onset in psychosis. abrupt onset is less than 2 days, that is within 48 hours, the patient becomes floridly symptomatic, then we call it as abrupt onset, and it has an excellent prognosis. The patient will respond very fast and he will achieve premorbid level of functioning. If the onset is less than 2 weeks, it is a good prognostic indication. Further, if the onset takes approximately 1 month, then we call it as subacute. Many a time people consider as chronic in nature, that is insidious onset. It has a guarded or a poor prognosis, my dear friends. So the onset, the more dramatic is the onset, the dramatic is the resolution. The more the abrupt in onset, the abrupt in remission. The slow or insidious in onset, it will be the slow and insidious in remission also. The way it starts, the similarly it ends. Now let's look into the history of acute psychosis. For simple reason, psychosis, if you are able to understand, if you are able to conceptualize, the whole psychiatry revolves around acute psychosis, my dear friends. Acute psychosis is a smaller version. The bigger version you can consider as maybe schizophrenia. If you are able to conceptualize acute psychosis, you'll be able to understand psychiatry very well. So let's look about the psychosis, especially acute psychosis, from the history lens. The first and the foremost is in 1887, Valentine Magnan discussed about Bouffée Délirante. What is this Bouffée Délirante? This is the French concept of acute psychosis, which had rapid onset and good outcome, which was very contrasting from schizophrenia, which was insidious onset and poor outcome. Here, the key feature is rapid onsets, that is sudden onset with psychotic symptoms. This onset is considered as like a flash or a delusional rush. Hence, it is called as Bouffée Délirante. Further, the French psychiatrist Pull 1987 formulated the criteria for diagnosing Bouffée Délirante. He gave the criteria. There should be abrupt onset, that is less than 2 days. Polymorphic in nature, that means it is not just a delusion. The delusion changes to hallucination, hallucination changes to mood symptoms, and sometimes visual hallucination, auditory hallucination. This polymorphic means many phases and sudden complete remission of the symptoms within weeks. Further, there should not be any organic condition and there should not be any antecedent psychiatric illness. That means they should not have any earlier psychiatric. Then it will be called as Bouffée Délirante, my dear friends. However, looking at this, Emil Kraepelin in 1896 proposed a dichotomy of psychiatric conditions. He gave dementia precoce, that is, later it was considered as schizophrenia, which is chronic in nature, poor outcome. Similarly, found that there is also affective psychosis. That means manic depressive psychosis, which is episodic in nature and complete recovery between the two episodes. These was proposed by Emil Kraepelin. But however, few of the researchers discussed about a third psychosis, which did not fit into the dichotomy, that is acute psychosis, my dear friends. Further, Carl Jaspers in 1913 discussed about reactive psychosis, and few of them over a period of time discussed similar one in psychogenic psychosis. This psychogenic psychosis is a very controversial term with regard to how psychogenic can be psychosis. So, the Carl Jasper discussed about reactive psychosis, reactive to a stressful traumatic event. There is a trauma and there is a reaction to the trauma in psychosis. There should be a temporal correlation between the stress and the onset of psychosis. Further, the psychopathology of the reactive psychosis should be colored with the content of the trauma. It should be acute onset. It has an excellent prognosis and outcome, no residual symptoms. Further, the later some of the researchers said the change of place or removal of the person from the stressful environment causes rapid resolution of symptom. Invariably, many of them considered as psychogenic psychosis because it is a defense mechanism against a conflict or an escape mechanism from a concept or wish fulfillment, my dear friends. This is a reactive psychosis given by Carl Jasper, my dear friends. Further, Meyer-Gross in 1924 gave a concept called as oniroid psychosis. This concept nowadays is not been accepted by many, but however, historically, it was a beautiful observation by Dr. Meyer-Gross. He called this when he observed a patient who had a vivid dream-like state with hallucination, altered consciousness, and a filmy kind of psychopathological experiences. Invariably, if the patient, when he comes out of this oniroid psychosis, the patient will say everything was a film around him. He feels it was vivid and a dream-like state. They are usually connected with catatonic symptoms and organic brain disorder. It is abrupt in onset, and suddenly the person goes missing. 3 days back, a person was normal, and he traveled to some place and suddenly is missing, nowhere to be found. Some of them you do because of this acute psychotic symptom, suicidal attempt, hostility, dangerous to other, and many a time they get into conflict with law enforcement agencies, my dear friends. This dream-like state is considered as oniroid psychosis, or there will be some confusion about the date, time, where they are. So oniroid psychosis, they talked about some criteria: abrupt in onset, vivid hallucinations, specifically visual, at times auditory and somatic. Sometimes the combination of all three will be seen by the patient. Altered state of consciousness, it is like a dream-like state, disorientation to time and place, dramatic narrative involving mystical and cosmetic themes. He will talk about God, philosophy, bizarre symptoms, and a state of trance. He feels that everything was unreal, but they was real. He feels that he is flying in the air or flying in a space, and he could see the dragon. So these kind of picture is seen in oniroid psychosis. And in 1928, Carl Klaes talked about cycloid psychosis. Invariably, he considered cycloid psychosis as dual in nature because it cycles between confused excitement and to stupor. In confused excitement, he's hyperkinesis, he moves around very fast, and in akinesis, it is stupor, running. Invariably a dual nature, where in one side he will be excited, in the other spectrum, end of the spectrum, it is a stupor. Hence, he considered as a cycloid psychosis. It is different from BPAD, my dear friend. This dual nature is seen in a single episode, my dear friends. Further, he developed a category distinct from Emil Kraplin's manic depressive psychosis and Eugene Bleuler's schizophrenia. That was cycloid psychosis. That means he did not agree with the either Kraplin's definition of psychosis or Eugene Bleuler. So cycloid psychosis was proposed. Further, taking a hint from cycloid psychosis, Carl Leonard expanded Kleist's ideas by defining three principles form of cycloid psychosis. He called it as anxiety happiness, confusional psychosis, and motility psychosis. So this is again the term, the way they presented to the physician. Further, by looking at all these things, Gabriel Langfeld in 1939 gave a schizophreniform psychosis. He is a Norwegian psychiatrist, divided schizophrenia into two groups: typical schizophrenia with insidious onset and poor outcome, The other one is a schizophreniform psychosis, acute onset and excellent outcome, but similar in psychopathology, considered to schizophrenia. This got attention and later was considered in the DSM 3, 4, and 5, my dear friends. These are all the various historical terms of acute psychosis, but in various cultures, acute psychosis has been given various names. For example, I mentioned in France it is considered as Bouffée Délirante. In Germany, motility psychosis, psycholoid psychosis, reactive psychosis. In Japan, it is called as atypical psychosis. That means it's neither bipolar disorder type of psychosis or a schizophrenia. It is atypical to both of them. That is a third psychosis. Scandinavian country, they called about psychogenic psychosis and schizophreniform psychosis. In America, it is called as remitting schizophrenia, good prognosis schizophrenia, hysterical psychosis, acute schizoaffective psychosis. In West Indies, acute psychotic reaction. In Africa, various terms like acute primitive psychosis, acute paranoid psychosis, transient psychosis. Similarly, in India, it was considered as acute psychosis of uncertain origin, hysterical psychosis, acute psychosis without any stress, acute schizophrenia episode. These are the various terms has been given in acute psychosis. Further, of late, to do research, you cannot use various terms, various definitions. In ICD, it was considered in ICD-10, it was considered as acute and transient psychosis. Similar thing was considered in ICD-11. Similarly, in DSM-5, it was considered as a brief psychotic disorder. Further, it was operationalized into brief intermittent psychotic syndrome called as BIPS. It was measured by structured interview of psychosis risk syndrome, that is SIPS. Further, brief limited intermittent psychosis psychotic symptoms, BLIPS. It was defined by CARBUS. CARMS means comprehensive assessment of risk mental state. So these are the various names, various measurements were used. Hence, at times it becomes very difficult to refer what is acute psychosis. To conceptualize the acute psychosis, you can see this. This is the diagram published in JAMA Psychiatry by Fazur and Poli and his colleagues in 2016. You can see how the ICD-10 got the inspiration from degeneration theory of moral, Bouffée Délirante. This is how it ended in ICD-10. Similarly, reactive psychosis 1913, further psychogenic psychosis and reactive psychosis. Similarly, if you look at the motility psychosis and how it contributed to DSM-5. So this is the conceptualizing acute psychosis and similar complaints which have been found here. However, the commonality among all this is acute in onset or abrupt in onset, short duration, excellent outcome, good prognosis, with or without treatment. This is how the acute psychosis was conceptualized initially. To summarize, my dear friends, acute psychosis are those with acute in onset, good outcome, duration not more than 3 months, presenting with delusions, hallucination, thought disorder, and these presentation may be depicting socio-cultural religious background and invariably associated with stressful event, my dear friends. This manifestation understanding of acute psychosis and phenomena varied across culture. Based upon their culture, the presentation was seen. Now let's look into the classification of psychosis. Invariably, psychosis is divided into two types: acute psychosis, chronic psychosis. Acute psychosis is the onset is less than 2 weeks and total duration should be less than 3 months. It has an excellent prognosis, hence it is considered as acute psychosis. Further, chronic psychosis, where the onset is more than 1 month and the duration is more than 3 months and poor prognosis. However, between acute psychosis and chronic psychosis, there is a term which is considered to be in DSM-5, that is schizophreniform psychosis, my dear friends. However, there is a third group which many of us believed, apart from bipolar disorder and schizophrenia, acute psychosis is also considered as a third psychosis and atypical psychosis, my dear friends. So atypical psychosis is nothing but acute psychosis or third psychosis. Let's look into the ICD-11 understanding about acute psychosis, which is named as Acute and Transient Psychotic Disorder in ICD-11. So let's look into what are the features. As the name mentions, it is acute in onset, transient. The onset should be less than 2 weeks, and they should not have any prodrome, my dear friends. That means the onset should be less than 2 weeks. There is no prodrome and no negative symptoms. Symptoms includes delusions, hallucination, disorganization, thought process, catatonic symptoms, confusion, and disturbance in mood symptoms, my dear friends. And symptoms rapidly changes from delusions to hallucination, one hallucination to another hallucination, mood symptoms, happy mood, crying spells, fearfulness. And this change occurs rapidly over a period of hours, my dear friends. And the duration should not last more than 3 months. The onset of disorder is usually associated with stress and also deterioration in social and occupational function. As I mentioned, there is a polymorphic in nature. Symptoms rapidly change within hours, and invariably there is a acute stress. And once the patient improves, there is a complete recovery to premorbid level of functioning. But however, please remember, in acute psychosis, it should not last more than 3 months. So invariably, all acute psychosis is rapid in onset, fluctuating course, polymorphic in nature, and severe so that it impairs his biosocial occupational function, and within 3 months, there is a complete remission. Let's look into those symptoms, my dear friends. The commonest is auditory hallucination, persecutory delusion, delusion of reference, very few will have delusion of grandiosity, thought disorder will be seen, visual hallucination, catatonic symptoms, sometimes disorientation or confusion will be seen, although it is less, and very few will have negative symptoms. These negative symptoms can have a poor outcome. So these are the commonest symptoms seen in acute psychosis, my dear friends. Let's look into the ICD-11 classification of acute and transient psychotic disorder. They are coded under 6A 23.0, acute and transient psychotic disorder first episode. That means it is the first time it is happening to that person. Currently symptomatic, in partial remission, in full remission, unspecified. It is based upon the response or improvement. Second classification, coded under 6A 23.1, acute and transient psychotic disorder with multiple episode. Currently symptomatic, in partial remission, in full remission, and unspecified. So this is how it has been classified, my dear friends. If you compare between ICD-10 and ICD-11 classification, there has been a phenomenal shift from ICD-10 to ICD-11. You can see here in ICD-10, there are various categories have been given. Acute polymorphic psychotic disorder without symptoms of schizophrenia, acute polymorphic psychotic disorder with symptoms of schizophrenia, acute schizophrenia like psychotic disorder, other acute predominantly delusional disorder, and these are the classical. Whereas in ICD-11, they have given only two, acute and transient psychotic disorder first episode. The second one is acute and transient psychotic disorder multiple episode. So this is the difference. Here in ICD-11, they have not considered schizophrenic symptoms or polymorphic in nature. The polymorphic in nature and schizophrenia symptoms are embedded in the ICD-11 itself, my dear friends. So there is a separate category has not been considered under ICD-11. Now let's move into brief psychotic disorder, which is equivalent to acute psychotic disorder in ICD-11. So in DSM-5, they call it as a brief psychotic disorder. So the criteria in DSM-5 is it should be sudden in onset, psychotic behavior, last less than a month, complete remission within a month, achieving premorbid level of functioning, and possible future relapse. Here, the change from ICD-11 is less than 1 month. In acute psychosis and ICD-11, they give up to 3 months, my dear friends. In DSM-5, at least one symptom should be there, either delusions, hallucinations, disorganized speech, or grossly disorganized or catatonic behavior. One of them should be there and should be classified either with stress or without stress. Sometimes with postpartum onset, especially in women after childbirth. The childbirth within 1 month, if it occurs, it will be considered as brief psychotic disorder postpartum in onset. So this is the classification which is given in DSM-5. Now let's understand the prevalence. How common is this acute psychosis? If you look at the Western literature, it says it affects both the genders, male and female. In the early part, it is common in men. That is in the second decade. In third and fourth decade, it will be in women. The Western literature says 3 to 10 per lakh population. But however, the Asian literature says it is 10 times more common than the Western literature. That means if it is 1 lakh, 3 to 10 per lakh, in Eastern countries, especially in Asian countries, it is 3 per 10,000 population. So it is 10 times more common. But however, there are no prevalence studies to talk about the exact cause. However, studies have clearly said that there is a high mortality in acute psychotic disorder, my dear friends, either because of dangerousness to self or others. Many a time they go missing. Considering this acute and abrupt in nature, the patient becomes rattled. He goes missing. Many a time they assault somebody and the public will beat them. This high mortality is the reason in acute psychosis we need to treat at the earliest. But now the question comes, what is the diagnostic stability? Is this acute psychosis will become schizophrenia? Or else this is acute psychosis which becomes BPAD? Or else it is only acute psychosis? Or else this acute psychosis is a delusional disorder prodrome? This is the various question which comes into the mind of researchers and clinicians. So let's look into the diagnostic stability. The first study done by ICMR study in acute psychosis. It is the largest study done in 1984 and 85. 4 places in India it was studied. In that study, over a period of 1 year, they found that 50% of the patient did not meet any criteria for schizophrenia or BPD. That means all acute psychosis, if you treat today, at the end of 1 year, 50% will remain as acute psychosis, other 50% will transit to another diagnosis. It can be schizophrenia, it can be BPD, or it can be delusional disorder. That means these acute psychosis, 50% is the diagnostic stability. Later, in 1992, Dr. Savita Malhotra and her colleagues did a study based upon the ICD-10 category program stability, and they found 40% continue to be acute psychotic disorder. So invariably, we can say 50% of the patient who present with acute psychotic future over a period of time, 50% continue to be ATPD, another 50% may transit to schizophrenia, bipolar disorder, delusional disorder, or even maybe a BPAD. Let's look into the differential diagnosis. Invariably, post-epileptic psychosis, drug-induced intoxication or psychosis. It can be alcohol, cannabis, stimulants, organic after head injury, infection, stroke, toxin, poison. Acute psychotic feature may be seen. Metabolic encephalopathy, like electrolyte imbalance, endocrinal disturbances, or else schizophrenia, mania, BPAD, or agitated depression. So there are various differential diagnoses are there. If it is a first onset, abrupt, then you need to consider as acute psychosis first. So what are the etiology? Apart from the organic etiology which we know, for the functional cause of acute psychosis not known. Invariably, it is genetic in nature. These genetics, which can be considered as epigenetic, under stressful situation, some of the genes gets activated and they may express into various neurohormones or receptors, leading to neurochemical hypothesis of acute psychosis. Many times, some of the psychologically based psychiatrists will consider it is the conflict which is causing psychosis. Invariably, it is a stress or else traumatic event leading to formation of various genetic phenomena, my dear friends. But however, at this point of time, the exact cause of acute psychosis is not known. Now let's move into the management. How to manage this? Invariably, whenever there is an acute psychosis, my dear friends, we need to start the treatment at the earliest. Once the treatment initiation is started, that is considered as therapeutic. From the day of diagnosing and the medication is started and to the time of complete resolution, of symptoms, that is a therapeutic dosage, to treat the psychosis. Later, we will give as a prophylaxis. Next 3 to 4 months, there is high chance of recurrence or relapse. Hence, we can give prophylaxis. And later, we taper and stop, my dear friends. So the management has three parts: therapeutic part, treating the psychotic symptoms; prophylaxis, so that it does not come back; and slowly tapering the medication. So these are the three important phases of management of acute psychosis. So this is the how the dosage is given. Invariably in acute psychosis, we say the dose which cured the patient should be continued so that to maintain well. So before we move forward, we need to understand in the management, history taking is very essential. Ask about the onset, duration of symptoms, past history. Look for any organic insult like infection, fever, seizures, substance use, bowel bladder incontinence, focal neurological deficits. Need to be checked in history. Thorough general physical examination is essential, my dear friends, to rule out organicity. At the same time, these acute psychotic patients will have extreme violence. They would have assaulted somebody. The public would have assaulted them. The patient would have shouted at the police or the law enforcement agencies, and they would have assaulted him. Hence, it is very essential to look for injuries on the body of the acute psychotic patient. Invariably, stripping and searching them is very difficult because the patient becomes extremely violent. Hence, you need to sedate them. And once they are sedated, please do a thorough physical examination for any bodily injuries. At times, we have seen the patient is beaten by the public at large. He will have rib fractures or internal organ getting bleeded or internal organ injury, fractures. And we will come to know only in the later part when the patient starts gasping. Hence, a good physical examination has to be done in acute psychotic patient when he has been restrained and brought to the emergency situation. If you are able to do mental status examination is excellent. Do certain investigation, blood test, CT scan, drugs for urine test should be done, my dear friends. This is the approach towards acute psychosis. As I mentioned earlier, acute psychosis should resolve within 3 months. Then why should we give medication? The need for medication is basically if the symptom is so severe, impairing his biological, social, occupational function. In this fast-paced world, imagine if he doesn't go to the job for 3 months, he will be kicked out of the job. Or else he may lose a semester in his exam. Aggression, violence, hostility. He may hit somebody, or the public may beat him up. Dangerous to others, dangerous to property, dangerous to self, suicidal attempt, catatonia, food refusal, delirious, wandering behavior. All these will indicate we need to treat the acute psychosis aggressively rather than waiting the patient to become severely ill over a period of time. Once you start medication, you need to educate the family members regarding how the symptoms resolution occurs. When we start antipsychotics, in the first week, biological symptoms will improve. That is, sleep and food intake will improve. In the second week, the general behavioral symptoms like agitation, hostility, aggression, arousal symptoms will come down. In the third week, emotions, delusions, and hallucinations will start reducing. In the fourth week, negative symptoms, and in the fifth to sixth week, the cognitive symptoms. The cognitive symptoms are the last to respond, my dear friends. This is how we should expect the patient to respond for antipsychotics. If the patient is acutely excited, violent, fearful, dangerous to self and others, and the patient is brought to the emergency or in the ward, in such a scenario, you need to provide chemical restraint so that he does not harm himself or others. In such a scenario, we need to consider rapid tranquilizers, my dear friends. You can choose either injection haloperidol or injection lorazepam, injection promethazine, or injection midazolam. Midazolam will be chosen in a situation we want to give sedation for a short duration. I choose invariably the combination of haloperidol and lorazepam. The dosage of injection haloperidol will be 10 mg and injection lorazepam 2 mg. In IV, I'll be giving them. Once I give this injection, the combination of 10 mg and 2 mg, invariably 50 to 60% of the patient gets a good sedation. Many a time, around 30 to 40% do not respond. So I will repeat after 15 minutes the haloperidol and lorazepam in 10 mg and 2 mg. Remaining 20 to 30% also will respond, my dear friends. Even if the remaining do not respond, again I'll repeat after 15 minutes. Here, my goal is to decrease their arousal symptoms, to decrease their violence, so that they do not become dangerous to self and others. I choose invariably giving IV. Many a time, I have seen injection promethazine, 25 mg, or else also called as Finargan. By chance, if the sister gives the injection in the intra-arterial, will cause sudden vasoconstriction, leading to gangrene, requiring amputation. Hence, invariably, I avoid injection promethazine IV. I choose invariably giving IV, my dear friends. So my drug of choice is injection haloperidol and lorazepam combination. Even if after giving 30 mg of haloperidol, 6 mg of lorazepam, if the patient does not calm down and he continues to be violent, I choose injection zuclofenthiazole acufase, that is acetate. Invariably, I will give 50 to 100 mg based upon the patient weight, my dear friends. I invariably give intramuscular. It should not be given IV. Intramuscular 50 to 100 mg is given. Or else, injection olanzapine 10 mg IM will be given. Most of the patient will be sedated by this chemical restraint. Many a time it may not be even a fraction of the patient may not respond to either haloperidol, lorazepam, either zuclofenthiazole, acufase, or olanzapine. In such a scenario, you may have to consider physical restraint. But you need to document the patient failed these trial, hence I'm considering restraint. And you need to do all blood investigation and discuss with the patient's family members and the seniors, consultants to see how to manage such patients. Further, you need to involve the family members because many a time this such a sudden onset of symptoms, the family members will be shocked. They will be wondering why this person is having agitation, why is he becoming violent, why is the strange behavior, why is he has become mentally ill patient. You need to sit and discuss with the family members regarding the good prognosis, need for treatment, supervised medication. We need to ensure the safety of the patient and other family members. And we need to make sure the patient is taken care appropriately both in the hospital and later at home. We need to counsel the family members regarding the ensuring the basic needs of the patient should be managed, minimize stress and stimulation, do not argue with the patient's psychotic symptoms or delusion, do not challenge them, avoid confronting the patients, encouraging the normal activities of the patient. These are very essential so that the family gets prepared to deal with the loved one going through acute psychosis. Now we need to consider oral medications. Any of the antipsychotics should be considered when the patient has florid delusions and hallucinations. Based upon the patient's age, past history of response, family history of response to certain medication, either we can choose risperidone, olanzapine, aripiprazole, haloperidol, or quetiapine. And the dosage are given. Invariably is a trial and error method, my dear friends. We need to discuss with the patient's family, affordability, how often they can give medication, how far they are from the hospital, what are the expected side effects, whether the patient has organic brain injury, compromised intellectual ability. In such a scenario, we need to choose arpiprazole, my dear friends. If the patient is highly excited, you may have to choose olanzapine so that it can cause sedation, or else quetiapine can be chosen. So, based upon the patient's profile, using the side effect of the medication for the benefit of the patient to calm down, we need to choose the medication. Further, the patient requires sedatives. You may choose adding benzodiazepine or else antipsychotics. This antipsychotics or the benzodiazepine is given to decrease their arousal symptoms and to address insomnia. Usually choose lorazepam 1 to 2 mg or diazepam 5 to 10 mg, clonazepam 1 to 2 mg or clorazepam 100 to 400 mg. These medicines are given very specifically for short duration to address violence or insomnia. What about the side effect of these medications? You need to keep an eye on that sedations, which is required, but if it becomes more sedated, the patient does not get up after 24 hours also. That is a warning sign, red flag. We need to titrate the benzodiazepines. Dryness of mouth, blurring of vision, constipation, delayed micturition, extrapyramidal symptoms, rigidity, dystonia, akathisia, tardive dyskinesia, postural hypertension. These are the things you need to keep in mind and address appropriately. If the patient is acutely symptomatic, it is worthwhile admitting the patient for a period of 1 to 2 weeks, observe them. Once the patient is settled, you can discharge and provide medication on OPD basis. There may be a chance of failure for treatment. Adequate trial for a period of 3 to 4 weeks. If there is no improvement or only partial improvement, that means it is a failure. We need to change the medication from one antipsychotic class to another different antipsychotic class, maybe second generation to first generation, or a combination of first and generation to second generation should be considered, my dear friends. At times, you may have to consider electroconvulsive therapy. If the patient is highly suicidal, homicidal, catatonic symptoms, food refusal is there, uncontrolled violence, aggression, and even in spite of giving maybe 30 to 40 mg of haloperidol, 10 mg of lorazepam, or even after olanzapine injection, zuclofenthiazole injection, the patient is extremely violent. ACT is the choice, my dear friends. Or else, even after giving a good treatment after 1 to 2 months, if the patient does not respond, then ACT will be the choice. Once the patient symptoms are resolved over a period of 1 month, should we continue the medication? Yes, prophylaxis has to be given, my dear friends. Once the therapeutic medication has been given, this therapeutic means the medicines is given to decreases symptoms. Once the symptoms are decreased, now we have to consider prophylaxis so that the symptoms do not recur and slowly taper and stop. Invariably, the medication has to be given over a period of 6 months in adequate dosage and cover the risk period, my dear friends. The prophylaxis is given over a period of 8 to 12 weeks, that is 3 to 4 months, my dear friends. And later, over a period of 1 to 2 months, reduce the medication. So the total duration of symptoms should be 4 to 6 months. Do not stop the medication abruptly. This can cause relapse. Hence, tapering of the medication is advised, my dear friends. However, long-term prophylaxis, that is more than 6 months, need to be considered whenever the patient has severe psychotic symptoms leading to conflict with law, suicidal attempt, homicidal attempt, getting arrested. If the person is from a high profile, if he is a doctor or a district commissioner or maybe a parliamentarian who cannot afford another acute psychosis, he may has to take a low dose antipsychotics. If the patient has more than 2 to 3 episodes, family history of acute psychosis is there, comorbid drug abuse is there, in such a scenario, we have to consider and offer them the long-term prophylaxis. Let the patient decide whether to continue the prophylaxis or not. Now, what is the course and outcome? A 6 month study by Sajid and his colleagues published in Indian Journal of Psychological Medicine They followed up 80 patients out of 89. After 6 months, they found 70% of the patient continued to have acute psychosis. That means there was no change in the diagnosis. There was a diagnostic stability, and after 6 months, 70% were completely remitted. However, 30% diagnosis changed. Some of them developed schizophrenia, some of them mania, some of them developed delusional disorder, and some of them depression, my dear friends. That means 70% do well after 6 months. What about after 1 year? This is an ICMR study, 1 year follow up done in 1984 and 85. This study was done in 4 places: Bikaner, Goa, Patiala, and Vellore. Here, the full remission was seen in 75%, full remission with one relapse in 9%, full remission and more than one psychotic relapse only 1%, partial remission and no psychotic symptoms 9%, and still he continues to have the original index episode 6%. So invariably, my dear friends, 75% do well in acute psychosis. What about the course and the outcome? Invariably, as per the diagnosis, they should remit it in 3 months. 75% of them will remit. Invariably, the relapse will be seen in first 2 years. Whoever relapses, it will be in the first 2 years, my dear friends. And various studies across the world, it can be UK, Scandinavian country, China, Thailand, Indonesian studies clearly says 50% of the patient continues to have ATPD. Couple of them will have relapses, and 25% will become schizophrenia. Another 25% will become BPAD. So acute psychosis is a valid, stable diagnosis. 50% will have. Another 50%, the change of diagnosis occur over a period of 2 to 3 years. Either they become schizophrenia or BPAD. So rule of thumb is very clear, my dear friends. Half of them continue to have ATPD and they remit completely. They may have relapse later. 25% will develop schizophrenia. 25% will develop BPAD. To conclude, my dear friends, acute psychosis need to be aggressively treated because they are invariably excited, violent. Many of them may end up in conflict with law, but treating them gives a good prognosis. It can be treated even at the primary healthcare center. Family involvement is essential. Family education about acute psychosis and providing prophylaxis over a period of 4 to 6 months is essential. Need for medication is based upon the severity of symptoms. Prophylaxis need to be suggested for those patients who are risk of relapse is there, and rehabilitation should be planned from the day one of the acute psychosis, my dear friends. For a psychiatrist, the most fulfilling thing is to treat acute psychotic patient. You can see a patient improving from a floridly psychotic state to achieving premorbid level of functioning within a period of 1 to 2 weeks, my dear friends. So that is about acute psychosis. If a psychiatrist is able to understand acute psychosis, why there is a sudden change from a one state to another psychotic state and suddenly becoming completely well. If we are able to unravel this mystery, we will be able to unravel psychiatry, my dear friends. That is about acute psychosis. Thank you very much for giving your valuable time. Stay safe.